you know, Paul, thank you very much. I mean, to take the time today. I mean, your talk was great. Really, have taught everybody just so much. So, thank you very much.
My
Great.
pleasure.
Same
Thank you
here,
for
Paul.
having me.
Really appreciate it.
My pleasure, guys. Be safe, stay healthy, and thanks for
All
letting me
right.
be part of it.
We'll see you soon.
All right. Thank you, guys. Bye.
Okay.
Bye bye. Thanks. And so we'll be taking a few minute break, and then Mike and Rich will come back for the discussion. And right as I did see that there was a question that came up, and it said, would you elaborate on GCC and optic nerve head RNFL agreement? And we can do that. So, Mike, that's the question that came in, and but I mean, why don't, can you just address that?
Yeah, sure. So I'm not sure what this was specifically in reference to, but if it's a general question about scanning in the macular region and the ganglion cells and looking for correlation to the retinal nerve fiber layer scans that we've been doing and around the optic nerve head.
Yeah, I guess so. And and Paul had talked in that one case about the GCC, and you saw that as being abnormal, and the optic nerve head was not.
Okay.
So I think we're I mean, I think there, let me just touch on just for a second. So I am cautious if I only see change on the ganglion cell or the macula test and not on the RNFL, because I think maybe there's something else going on in the macula. I mean, there are rare or infrequent examples where the change is first within the macula, but that's not usually the case. Usually they're, but I think the bigger problem in the case, or I should say not a problem, but the case that Paul showed was that he did not share panel maps. Panel map, each of the companies has a way to link the optic nerve head, the nerve fiber layer, and the macula together, lining them up. And when you do that, even in that case he showed, there was some loss inferiorly at the yellow, the 5% level, that was starting in one of the eyes that was extending out to the macula. The macula was just denser. And that's often what you see. And, now whether it's, the Topcon, the Cirrus, or the Heidelberg, they all provide printouts or mechanisms so that you can see in essence a wide angle view and getting the gestalt of the entire region, as compared to saying I'm only looking at the RNFL or only looking at the macula. Is really useful, in that case. So yeah. So while, I mean, Dr. Singh mentioned, as I said, the GCC as being an indicator, even though the optic nerve RNL was unremarkable. I mean, at least for me, as I said, I'm more cautious when I only see changes in the macular region. But reality is there are often changes in both, and you just have to look carefully. And by having the panel map type displays, you start to see that. Mike, your comments as we take.
Murray, you're spot on. I think we know that there's just so many artifacts that we've seen that show up in the macular ganglion cell scans. And so I follow exactly what you say, which is I do not rely on ganglion cell alone changes to diagnose glaucoma. But when I have ganglion cell correlating in the same anatomic region with the retinal nerve fiber layer, then I'm much more assured of what's going on. And to make sure I look at a fundus photo or ophthalmoscopic examination of the macula and make sure that it's not an epiretinal membrane, not some other maculopathy or something else that's going on.
Exactly. Yeah. Because they can mimic it if in that case. So,
yep.
So, great, great. So, if you can provide and just email back, to Kelly, any topics or anything going forward, you know, that we may want to use as future topics. I mean, we welcome that. I do like the idea. Again, we did this a couple of years ago of just the post-op review of the MIGS devices, but now they're getting far more complex. It would be useful to go back to that. Really would. So with that, Mike and Rich are going to be taking over at 4:15 of just starting and leading the discussion, and there are a lot of topics. But so in that, and as we're talking, questions are starting to come. So in this case, does ERM increase GCC? Really, don't be sorry for the question, bombardment. Yes, it can. It does increase, or you see thickening, but more often the epiretinal membrane can show thinning and thickening, because it thickens in one spot and you may have a dip somewhere else and areas start to get flagged. So an epiretinal membrane can do that. As Mike said, macular edema, diabetic edema, macular degeneration. There are a host of things that can end up flagging areas in the macular region that can be segmental or regional, and that may look like glaucomatous damage. So it's why it becomes important just to carefully look and see what's going on in the OCT. So with that, I think we got the questions caught up from then. So let's take a break, and we'll, and then, see you back now in 10 minutes.
Yep. And just so everyone knows, what we're going to do to facilitate participation by anyone who wants to is we're going to promote everyone who's an attendee onto the panelist side. Kelly's going to do that. So if you want, and we certainly encourage you to share your video, your audio, and we're looking to have an open-ended discussion on whatever aspects and topics are on your mind about education of our students within the field of glaucoma. Rich and I have a couple of ideas and things that we will throw back and forth. And if you want to join in, please do. We're here starting at the 1:15 for as long as we go. And we'll take a short break here.
Great.
Thanks.
Okay, Mike, thanks. Nice day here in Chicago.
All right.
Thanks, Murray.
All right, Murray, have a good
Murray,
show.
have a good time, baby.
I will do that. Hopefully, Rich, yesterday it poured.
I'm sorry,
Yes.
but you've already sent me the audio.
You can, I think you can help the students with not the technique, but actually interpreting what they're seeing. But at some point you have to teach them how to use a four mirror, because they're really missing out. So I guess what I'm curious about is just what the other schools are doing. Are you making students do four mirror? Are you, is this a valuable thing to talk about?
So Danica, can I finish my rant?
Please.
that started this. I guess my frustration is, and I am frustrated, because I hear what you're saying, that, okay, seeing the angle in 3 mirror, we've heard that for me 30 years now, but there's no transition because it's not on national boards. And even if we require it as a check off in the clinic in 3rd year or something like that, it's just nonsense. Okay, so this is offline, and we're online, but I'm like speaking freely here, so I apologize for the animation. But I'd like to turn everything upside down and say, why can't we teach 4 mirror off the bat? I mean, if you just do it a couple dozen times, you'll get good at it. So the first 12 times you won't know what the hell you're seeing. They don't know what they're seeing with the 3 mirror, and then they don't own one. And yes, they can borrow one in the clinic, but we know they never do. Then they never own one in practice. So I'm just trying to blow everything up and say, you know what? I just disagree. I think we should teach 4 mirror from the beginning. I know it's not going to happen. I know, national board is going to do what they're going to do, but that's my frustration.
One thing would make it happen, and that's it. It's the board.
But
That's right. That's the only thing.
It's the only
And we-
thing that would make it happen.
Oh, we don't teach to the national boards. I've heard that, my whole life. Yes, we do. We all have to have high pass rates for our students. Otherwise, we look like crap.
Well, I think that it does, if you can do a 4-mirror, you can definitely do a 3-mirror. So it almost kind of does make sense to teach the 4-mirror first and then say, oh, well, for your boards, you're going to have to learn to use this one 3-mirror, but that's really simple once you learn to do 4-mirror. But I guess I think too, I don't know where it comes in your sequence in your procedures, laboratories or whatever, but for us, it kind of falls in this, you don't have to be able to do this to go into the general clinic. And then you sort of, it becomes a little less consistent in how the students are taught. And I'd kind of like to have them taught very, much earlier when they're learning just to do slit lamp. Okay, you do slit lamp, and then sometimes you use an additional thing when you're doing slit lamp. Where do you guys place that?
You're holding a 90 diopter lens up, so hold a gonio lens up. What's the difference?
Mm-hmm.
Bina has her hand raised. Hi, Bina, how are you?
Oh, shut up.
Hi,
And
hi,
and
Rich.
I know Bina teaches procedures, so let's,
Hi, Bina.
Hi,
Bina,
Michael.
Straight.
Okay, so Maureen and I teach together. We introduce gonioscopy with the 3-mirror, partly because, yes, it's more stable. You can see the structures a little more kind of wider width-wise.
Of course.
And then we use a tear gel for the coupling solution in the beginning before you switch to Celluvisc, so that they can get it without all the and feel confident in putting it on. Later on, we do introduce them to the 4-mirror, and then I think they're a lot more comfortable with putting something on the eye. Last year during the pandemic, we had reduced number of labs, and we introduced the 3-mirror really very quickly. Right after the 3-mirror and then 4-mirror right after, like literally. And it was messy. And like you said, they need to keep on trying it till they get comfortable. But I think in the time that we had, we wanted to introduce the key procedures. We didn't think they were quite as confident as ready as if they would have had a little more time and then done it towards the end. And then the 3-mirror has the multiple reasons to use it for the peripheral retina. So we make our students buy the 3-mirror, but we don't make them buy the 4-mirror. And then a lot of the clinical rotations really get them to do 4-mirror, but at least they're introduced in the second year fall semester. That's when we teach it.
Again, my argument would be they're never going to use 3-mirror in clinical practice. I won't say never. All right, I'm a little biased. I'm a glaucoma guy. Blah blah blah. But they're clearly not doing gonioscopy, and I just don't think that they're going to do 3-mirror. And I don't know.
Michael, at the
But they
point
have to
that
know
our,
how to do it. They have to know.
go ahead, John, I'm sorry.
No, they have to know how to do it. I mean, you don't not teach it. It's a skill they should have. I mean, that's a basic entry level test. I mean, I'm with you, Michael. I haven't used a 3-mirror in decades, but I still agree with the method of what Dr. Patel described. I think is a solid way to go about it. I mean,
well, then maybe one suggestion, maybe have them not buy a 3-mirror, have them buy a 4-mirror.
okay, well,
You know what I think happens? Let's say our student goes to John McSorley at Bascom, and John's going to make them use a 4-mirror, but then they're taking the board in November. So as soon as they are done with you, they are going right back to the 3-mirror. I mean, that's just the reality of it.
and what they'll sometimes do is after clinic, they'll practice the 3-mirror again. They'll be more familiar with manipulating things around the eye. They'll be more familiar with the anatomy. They're not going backwards. It's just the technique of applying one cumbersome lens versus one that's not, but it's still a skill set. I know I made some remarks earlier this morning. I wasn't necessarily negating the value of the 3-mirror. It's just I think that for practical reasons, and there are many, the 4-mirror is a better lens for the discussion about glaucoma and the daily care of glaucoma patients. But you're right. When we haven't had students since COVID, but hopefully we'll reenact that. But they would spend time after clinic hours practicing their 3-mirror again when they were getting ready for their board exams.
So I teach the methods course at MCPHS, and we teach both. So in the summer between their first and second year, so pretty early on, during the same lab where they learned slit lamp and tonometry, they learned gonioscopy, and they learned 3-mirror first, and then they learn 4-mirror. and they are required to buy both so they can do both in lab. In our in-house clinic, we ask them to do 3-mirror because, for one, yeah, they got to kind of get good at that for boards, but then also we find, since we're teaching them both and we're working with them on both, we see over the years that they actually have more trouble with the mechanics of the 3-mirror. So we keeping it on the eye and rotating it without breaking suction. So we have them practice that in clinic, in our in-house clinic, for a couple reasons, to hone that skill. And then also, you know, the optics is a little better. They struggle with the optics on the 4-mirrors, and we want to be able to really go over those visuals with them while we have them. And we do know, because we've surveyed our kind of off-campus preceptors, and we know that for the most part, they're using 4-mirror when they leave our campus clinic. So they're going to get that as they rotate through those clinics. So they are kind of getting both. And we find that they actually struggle with the mechanics of the 3-mirror. So it's worth it to spend that time, because when you have to do it, you have to know how to do it. There's some patients where you need that suction or you're not going to get a view. You need that stability or you're just not going to get a view. So they have to be able to do that. They really do need both. So if you can, do both, right?
Rick made a comment, I think that's who made it, about students thinking to use a 3-mirror for the peripheral fundus. So there is a reason for them to be able to get that thing on the eye with fluid. So I think that's a good point. Does anyone else want to discuss this? I don't know if there's a way to fix this problem. You know, again, until the board did anything, or it's up to us to make sure that our students use 4-mirror when they, and give them the rationale to use it. You know, maybe that's not as clear as it should be. I'm not sure about that. We lost Anu because I was going to ask him, you know, because he deals more with our 3rd-year students. Anything else on this issue? Danica's given us a tour of the house. So I had another question, and it was one of the things that Michael and I had put on our list, was the whole issue of testing the central visual field. What are people doing? What are they teaching? You know, are you using 24-2C? Are we using 10-2? Are you not using anything to sample the central visual field? And then does Cedar Faster get involved in all of that? And Anu jumped out and jumped back in before I had a chance to ask him my question, but that's okay. We'll catch him this time around. So what are people doing regarding that? And what are their feelings regarding the whole increased sampling of the central at your institutions?
You want me to start?
Sure.
Somebody else can start. I don't want to monopolize here. We're doing both, I guess, still, Rich. We have the latest software, fortunately, on all the perimeters. So, and we've educated most everyone. Like many things, I think it's slow to adopt a change over to the 24-2C and the CETA Faster. And we know about some of the foibles with CETA Faster strategy and stuff. And so there's a lot of 10-2s for some of the early diagnosis. I guess it's still making sure that we teach our students to make the right decision, choose any program for early stage glaucoma and try and identify central field defects. But I don't know that we have a clear pathway from my standpoint right now.
For us in Houston,
Clear single pathway is what I meant to say.
For us
ahead,
in Houston, I teach the didactic course, and I teach, you know, 10-2 for early loss and correlate it with macular ganglion cell loss, and talk to them about the 24-2C. But once they get down in clinic, it just depends on who they're working with, right? So there are going to be some people who've fully adopted 24-2C. I have to say, I think patients have a hard time with the CETA Faster, and a lot of my patients do. And so I tend to kind of separate them out, and I don't do 10-2s on everybody. But I think it really, and I guess it would probably be this way in a lot of places, we don't say at the University of Houston, when you have a glaucoma patient, you're doing this visual field. It's up to the individual faculty member.
Anybody else with comments on that?
Danica,
Okay.
to that point, we've been
Yeah.
we've been thinking about, and Rich knows this a little bit because we recently concentrated our glaucoma care within our primary care service. You know, we had it spread out throughout our entire very large primary care service. And recently, I more or less decided that I think we need to concentrate it and have sort of a more select group of faculty that are doing it. And that brought up this question of, you know, do we need a preferred practice pattern above and beyond what AOA has? And, you know, is there some consensus thing that we could adopt within ICO? And, you know, how do we make these recommendations? Because not everyone is able to keep up with the changes in instrumentation and technology as we are here within this group. And so, you know, I realize, you know, we are looked at to make these recommendations for faculty who are, you know, doing glaucoma care, but not on every glaucoma webinar seminar thing. So it's a good question that you bring up about, should we be making these protocol, I don't know, guidelines?
Well, and also I think about the fact that you have people who are going to go on externships where they don't have this technology. They're going to go to practices where they don't have that technology. So I would
Yeah.
certainly at least want my student to know, hey, on these people that their 24-2 looks normal, I don't have a 24-2C, their ganglion cell looks bad, I'm going to do a 10-2. So I think it's the understanding of it more than which specific test should you be doing. But that's just what I think.
That's a great point, Danica. And Maureen has her hand raised. Maureen, if I could just add one quick thing, because I thought what Danica said was so important, because what I've been telling students too is that when you go on externship sites, you may hear entirely different things about the macula, and you're probably going to know more perhaps than some of your externship supervisors, particularly if you're rotating through a private practice or whatever. So I think your point's well taken. I'm sorry, Maureen, and then Anu.
No, I just wanted to say, I think fields have taken a hit with COVID. And I think a bad hit. And I think people are doing less and less fields and just doing OCTs. And I'm a little afraid that that practice is going to continue unless fields are going to be done when they should be done. And I don't know if less field, I mean, COVID, we've had COVID a long time and field machines were stopped for a long time. And I don't think as many people are doing fields as they should even now. And I don't know if you guys have noticed that throughout the country, and even top-notch glaucoma people who we're referring to for surgery and that are doing a lot less visual fields or even wanted to see the field. So I didn't know if that was just in Northeast here or throughout.
Maureen, I've heard of those type of things on random occasions from my students around the country and from others around the country. So I think there is some aspect of truth to what you're saying. I also keep getting a lot of questions about virtual, you know, perimetry and perimetry with goggles and whatnot. And in my mind, not ready for prime time perimetry. So I think people will always try and avoid this, you know, horrible procedure, even though we've got it down to 2 minutes an eye. But notwithstanding, like Danica said, see to faster is not great for a lot of patients, and it's just too many high false positives.
If I can again volunteer Anu is the head of our Environmental Safety Infection Control Committee at SUNY. So he has done yeoman work during the pandemic. So, you know, do you feel we've done less? Let's forget the first few months of the pandemic. Obviously, we did less visual fields, but now that we're back to kind of whatever normal is these days, are we doing the same number of fields? I don't even know.
So I mean, I am. So in my clinics, I'm right back to where I was. So I'm absolutely doing it. And I think most of our other glaucoma providers are also doing the exact same. You know, in terms of enhanced cleaning protocols, you know, just because of the fact that, yes, you know, that we do have the aerosolized alcohol, you know, we do use that to some degree, but a good mask, tape along the nose for our patients. We have, I think, 3 different visual field machines. So we do separate our patients. So there is time for the machine to air out, that we're actually right back to what we've been doing prior to. So,
Hey, Anu,
yep.
did you guys install those plexiglass barriers that Zeiss came up with?
No.
Yeah, we put those up and now we've taken them back down. I
Yeah,
mean, I'm not sure that they were good for anything. Other than that, we never covered the perimeter. Well, we don't cover the
Correct.
perimeter anyway, let's be honest. But, you know, they came out with these plexiglass barriers for the perimetrists for my students. And I'm like,
Right.
come on, what, you know?
Right. So, yeah, I mean, we were lucky because we had these little small rooms for our visual fields where, you know, we can keep the door open a little bit, and we do tend to air them out. So,
Yep.
In terms of what protocols to use, really what I talk to my students about is really what is the value add when it comes to the 24-2C. So for example, in our primary care clinic, if they're doing screening visual fields on patients and they want to use the 24-2C protocol, I think that's perfectly fine. However, even if there's one tiny little spot that's missed on it, you got to run a 10-2, and then you can be running the 10-2 if there are defects there anyway. So in the glaucoma service, I don't run the 24-2C at all. I run my 24-2s, usually now CETA-FAST. I'm still thinking about CETA-FASTer, but usually the CETA-FASTs. And I run the 10-2 based on the patient's anatomy, based on their ganglion cell, based on the nerve fiber layer, looking at where I would expect defects based on the nerve. And we kind of move forward from there. So the 24-2C in my glaucoma clinic, again, there's no value add, in my opinion.
Any other comments on that?
Well, I can just comment. In our glaucoma clinic, we don't even have, access to the 24-C. So we do 10-2s in patients that it makes sense, and we just alternate it. We alternate those tests with their 24-2 on alternating visits. And Maureen, we actually lost our visual field clinic. So we had separated out the visual fields to a tech visit where they came and had their visual fields and OCTs at a separate tech visit, so that when they came in for their glaucoma visit, we had their tests from a week before, we analyzed it and everything was more streamlined. And from COVID, we couldn't do that anymore because we had to minimize the number of visits for the patients because our patients have to test before each visit. So the patients actually refused to keep coming for all those tests. They said, you got one shot. So we no longer, Maureen, even have a visual field clinic, and we're having to squeeze it in now to their glaucoma visit. And so, yeah, it's harder. And so we are doing less even now because of our scheduling. It's just harder to fit back in there. So it definitely affected us. And we're looking at ways I don't think we'll get back to normal until the school no longer requires testing for the patients. It is an issue.
Michael, can I ask Mike a question that we discussed at length at Berkeley, if some of you were there?
Yeah.
And it's one of my favorite topics. Are students performing your OCTs in visual fields? And if you were in Berkeley, it really was a big discussion because, and I'll just tell you what I had said. I said at SUNY a few years ago, because we have an imaging clinic with imagers, our students, other than in the laboratory and doing a handful of OCTs in visual fields, they don't get much hands-on. Actually, what occasioned it, quite honestly, was I got a call from Finger Ed, and Murray, he was very blunt. I got this student here, and she doesn't know how to run a visual field. She ended up getting an A in the rotation, by the way. And I said, yeah, and a few years ago, we decided that we have 100 students, and we can't get them enough experience. And so we're getting crappy fields and crappy OCTs, and we just stopped doing it. And, I think other than Michael, and I don't know, were you there, Danica? I'm not sure if you were there. it was most schools seem to be having their students do the actual OCTs in fields. And don't get me wrong, I understand the rationale for having students do them. There's definite education there of actually watching a field happening and doing a number of those, but we just can't do it. So has anything changed? There's nobody on from oh, we do have someone from Berkeley, I think, with us. So it was actually a very big discussion. So I don't know if anybody has any interest in jumping back to that or just moving on, but it's always something I think about, because I do wish we could, at SUNY, we could get our students a little more hands-on, but we just can't do it. We're too busy, and it just doesn't happen. Oh, where is Glenn? I don't know where Glenn was. Glenn, are you on page 2?
You may be in the regular group and not in the.
Oh, that's right. Yeah. Some people are not panelists. Thanks, Glenn.
Maybe I can try to promote him again if he wants.
Yeah.
Rich,
Okay, so there are others out there, which is great, because I thought
there are a couple
in front
other.
of me are the others. Terrific.
Terrific.
Hi.
So, wait, Rich, a little bit of our compromise. Sorry.
Who is
Has
speaking?
been. I'll shut up.
Somebody
who
was
was that?
speaking, but I didn't see who it was, and I don't think Michael did.
Dr. Whiteside's trying to speak. She's
Oh, yeah, okay, there we go.
Okay, can you hear me? I have kind of poor reception here.
Yeah, the reception's a little funny, but we got you. How are you?
Okay, good. Thanks.
Good.
Great program. I enjoyed it today. What I was going to say is at Berkeley Optometry, we are still having the students do visual fields and imaging. But I find, like, I can talk about my own clinic, is that I tend to be in there with them, especially at the beginning, to make sure that they get off to a good start, they give good directions and things like that. It's a very painful process, but at the end, they become better at analyzing it and troubleshooting it and recognizing false positives and things like that.
Yeah, I do agree with that. I just, we're just unable to do that. But yeah, that was kind of the place where Berkeley was, 3 years ago when we were there and had the same discussions. Can anybody else weigh in on this? Or Danica, what are you guys doing? I
Yeah,
forget.
in Houston,
talked
we
about
don't have our students do the OCTs, and it's really just exactly what you said. We want quality, consistent
Yeah,
hands, and we feel like 200 hands on our very expensive instrument is not exactly what we want. We do have our students run their own visual fields. It's interesting because what the students want to do is like push the buttons, and it cracks me up because I literally don't know how to turn it on. And maybe that should be embarrassing to me, but it's not. I don't know how to turn it on. I don't know how to obtain a scan, and I rely on my technician for that. I kind of think like a neurologist or a radiologist probably didn't know how to run the MRI, but they know how to interpret it, right? And so I guess that's kind of the mentality that I've had, but we don't have our students doing, no, we have a satellite clinic where they operate differently. They let the students run the OCTs. We just don't at the college.
Rich, I don't remember if I mentioned in the past, but one of our imperfect solutions to this was to use work study students. So we have, work study dollars from federal government, whatever, wherever it comes from. And we then select first and second year students who've had some training in performing visual fields. And it gets at least, a number of students. And so we have all of our different, 2 floors and multiple clinics. So there's actually a fair number of students who will do field testing on a weekly basis in a certain clinical session. And, it's way imperfect because a lot of students don't get that hands-on experience, but at least some do. And, I echo everyone else's thoughts, which is doing it teaches you a lot, but it's not impractical for us to teach all.
yeah. Bridget put into the chat box at MCPHS, we have students do fields and OCTs, and the results are terrible in all caps. We end up repeating a lot, but they learn, and that's the trade-off. Absolutely. Drew, you're on mask there. Hey, buddy, how are you? anything that you wanted to add to this in regards to, not necessarily at Southern, but maybe at the VA or whatever?
I mean, I'm in the South, so I don't think anyone actually believes COVID exists down here. Would be my first thought process. But yeah, I mean, it's echoing the same conversation from Berkeley before. I mean, there almost has to be some outcome basis of, okay, we say all this nice stuff about all the value of teaching for the students when everything becomes more and more automated, but what's the outcome to the patients? So is there anything actionable that shows that us, putting the student that may or may not be engaged in that, COVID festering room for a short period of time is actually going to result in improved outcomes with our patients in the future versus them just reading excellent perimetry, that chapter, and having good perimetrists. I mean, at the VA, we have perimetrists and we are absolutely psychotic about quality with them. And I see just garbage when I go over to SEO. I don't want to run fields because again, I can be very, very distinct in what I require. And I mean, this, you guys touched on the 24-2C and all the other stuff, and we're in a transitional zone there, but I just get garbage no matter what I want. I mean, it's like, this needs to have gaze tracking. I don't get it. So, I mean, what's the oversight in individual clinics? Obviously Dr. Whiteside sounds like she's doing an awesome job, but like, if there's not oversight in the teaching, once you get to fourth year on rotations and when you get into in practice, show me value. And so I'm with you, Rich. I'm perfectly okay with them not getting that experience. And maybe I'm just a little bit out there on that, but I think the theory of what Danica's teaching in clinic about 10-2 versus 24-2 and the absolute importance of good perimetry and having a good perimetrist is critical, but does it actually need to be done? And I mean, everybody's going to have probably opinions on that, but show me some data that shows it makes a difference.
Thanks, Drew.
But if we don't educate our students on how to do it, our students are going to be practitioners and working all different environments, and they might just have a high school graduate being their tech. They have to teach their tech how to do it. So
that's the constant argument that always gets stated, but what's the volume that they actually experience in clinic, and how do they actually teach their perimetrists? So, hey, I teach you the theory. I did 2 or 3 in a lab. I saw 4 that I did craftily fourth year, and I'm teaching an actual person that, high school graduates can be really intelligent people.
Oh, I didn't.
And I'm just going back.
Implying they weren't intelligent. That isn't. But
I'm doing extreme counterpoint on you. That's all. That's all I'm doing there.
No, I mean, Maureen brings up something, as Drew said, that comes up all the time. So I guess the question then it almost comes back to, what can we fit into that 4-year program that is going to give us the highest yield or give us the best practitioner at the end of the day? Yeah, I mean, Maureen, some of them are going to be put in that position. And again, I'll bring it right back to Murray when he called me that time. It's like, how come this student can't do a visual field? So that kind of got that discussion going with him and led to the discussion that we had at Berkeley a few years ago. So yeah, point taken. John, John is, you have so much experience, John McSorley, with perimetry and, you have thoughts on this? I'm sure you have more text than anybody.
I don't know. I would like people that enter the profession to know how to operate the equipment. I don't know that. See, I would resist it here because that would be exploitive. I think when they're on their 4th year rotations, I think they should be not doing those types of things. Although when I was on my 4th year, I did them when I was at the VA. And so I don't know where the balance is, but I would err on the side of not exploiting them on a higher volume clinical side. On the other side to that, I mean, however far you want to carry this extreme, I mean, I have students that don't think they should ever learn how to use a retinoscope because we have autorefractors. And it gets silly, right? So I think they should know how to operate the equipment effectively. And I don't know if that's accomplished through a part of an OTM lab or whatever that you do, but I don't know the answer to the question, but I think it's almost a disservice to them to not let them know how to operate something integral to their practice, but at some point, is it the school's responsibility, or do they just have to learn that as part of their self-study? I don't know the answer.
Yeah.
Rich,
Again.
I think, Rich, I think this is a situation where our old rule of see one, do one, teach one may not apply.
Yeah, you
See
gotta,
one,
you gotta see
don't do
100,
one.
do 100 and teach 100 or something like that. No, I think, John, that was perfectly said. You know, it's just a matter of finding the time in the curriculum to get it done. I mean, it's not like at SUNY, they don't not touch the field machine in the laboratory in OCT, but it's minimal. You know, it's just enough to maybe, yeah, turn on the button, turn on the machine and, you know, align a patient. And we all know that that's not one of the strong suits of many of our students is aligning patients. If you ever watch them try to do a field, it's usually fairly horrific.
Even patient instruction. I mean, I think patient instruction is probably a big thing. That's half the
Yeah,
battle.
you're right. I mean, you know, if we just had a little
Yes.
more time. If we just got
So
rid
has
of the
anyone actually,
retinoscopy, would be good. We'd have all the time we wanted, right, Maureen?
yeah,
No, I'm a retinoscopy believer.
No, I was one of Maureen's students just a couple of years ago, right?
so what's
was
it
John.
take to
John
actually
was my
achieve
student and
proficiency?
so were you. And
I didn't
Bridget,
hear you, Drew.
Oh yeah, I'm saying, so again, if we were gonna, what does it take to achieve proficiency? Has anyone actually looked at that as a perimetrist? If we're teaching them in the school, it's like, okay, you gotta knock out 15 third year, like what's it actually take?
Drew, that's a great point, because I can tell you, that's how I made the decision at SUNY. And that's kind of how I made the decision, that they just were not going to get enough cases to become proficient. That's exactly how I made the decision from an educational standpoint.
but you guys have techs. I would say most of our clinics, we have tons of community health centers. We don't have techs. They have a couple of preceptors and maybe 8 students. And, you know, the students have to do the field. So with each setting is different. You know, at the VA, when I worked at the VA, we had a wonderful tech. And we'd also have sometimes we'd put the tech in with the student. So the things would
so-
come out right, which was a luxury. I get that. But it's not, you know, it seems so easy. Just follow the instructions that I have on the piece of paper. But it doesn't work unless they do quite a few.
Kind of nice to see that this is still an interesting topic. So I think we can revisit it just about any year.
That's right.
Keep having the discussion. Hopefully we'll be live somewhere next year. I think it's still SUNY's turn, so maybe we can do that.
Rich,
I-
should we transition a little, or what do you
Yeah,
got
I think
next?
so. I think, you know, we're kind of in the same place as we were, but maybe there's a little more swing toward, you know, imagers and so forth. But, you know, if you don't have imagers, then I think the point is also moot. And that's what changed it for us. We got the money to hire some imagers. So
Yep.
that turned it all around.
Yep.
Michael, you have anything?
Nothing more on this. I thought maybe we try and figure out how we're going to teach MIGS to our students, given that.
Yeah, that's
we had
that's certainly on our list.
A to Z potpourri from Paul Singh.
Yikes.
Exactly.
The problem is not teaching mix. The problem is, what do we get rid of? You know, I'm sure all of you have X amount of hours. And it's not that anyone on this talk couldn't teach mix. You know, it's kind of easy. I don't think it's all that stressful, or we could get someone to come in who actually physically does it and teaches it. But if we have a surgeon come in, and that's 2 hours. So somewhere I had to get rid of 2 hours of cases. I was wondering, I mean, do they let you just expand at your school? How many hours you teach glaucoma? I mean, I think that's more of the question. And I would be, you know, love it if you could teach me how to keep adding.
Maureen, the only thing I've tried to make sure that we do, and Ashley as well, who teaches with me, so Ashley gets a lot of the credit here, making sure we don't overlap repeating information from other courses. The people who do anatomy, we rely on them to do a lot of the anatomy that we need in glaucoma. So, I used to repeat a fair amount of that. I don't do that anymore. And I really have tried to, I would repeat a lot of pharmacology, and so we re-examined our curriculum and tried to make sure there wasn't as much overlap. And Ashley and I decided, like, okay, you have to be prepared to our students before you come to class, all those things that you were all doing, probably better than me and more than me. But I am, I don't have a hard time sometimes cutting out stuff I used to. And as I've gotten older, I'm just like, what, this stuff is just going nowhere. And I'm trying to keep current. So again, that's maybe my own personal bias. And I have, to Drew's point, no outcome measures to know if I'm doing anything correctly. I mean, I hope my students can pass national boards and whatnot, but there's a lot of information. Fair point.
So Maureen, here in Massachusetts, we had the luxury of making we now have an expanded scope of practice argument to our university, and we got an extra credit hour added to the glaucoma curriculum. I don't know what you can do in other states, but that's what we did here. And then another thing, I mean, they don't know that the stuff we were already teaching anyway. I mean, we made the argument and it stuck.
That's good. Love it.
And another thing that we've done that we just started trying out, we're going to see how it goes. As you know, we have glaucoma 1 and glaucoma 2. Glaucoma 1 is more foundational. Glaucoma 2 is more problem-based learning and cases and stuff like that, more treatment and management. And so we've done more of a flipped classroom type thing for our glaucoma 2. So when you do that, you can take a lot of that didactic stuff out, give it to the student, make them responsible for it, and they come to class ready to just apply it to a case. So that's how another way that we bought time. We're just starting it. Seems to be okay, but we'll see.
Good points, Bridget. Thanks.
What about in the clinic? Does everybody have access to all of the MIGS procedures, through your surgeons? Probably not, I would guess. It's certainly changing rapidly. SUNY, it depends on who our surgeons are, and we just lost 2, so the whole thing is turning upside down on us. So I don't know. Maybe John would be the one who probably has access to every MIGS procedure through the surgeons. I don't know. I don't know.
No, it's very surgeon dependent. People go with what they like.
Yep.
Right.
Do an iStent and somebody will do a Cahook dual blade, and I'm a little biased because so much of where we're going are patients that are beyond the point of a mix, right? So still, majority of patients are trabeculectomy and glaucoma drainage devices. The ones that are coming through. I've been impressed with the few that I've had. I think I'm a little biased because just the particular surgeon, I saw more iStents than I did anything else. But it's very surgeon dependent. And I don't know if you've ever had this experience, but surgeons can be a little stubborn. I don't know if you had that experience. They don't want to change. They're locked in. They have their thing. They're believers, and it's hard to convince them otherwise. And you can't say, well, would you mind giving me a little more experience with this? No, that's never going to work. But I guess the best thing is to work with a group of people and keep your eyes and ears open and benefit from the experience. But
I just got the director of our surgery center in my office on Thursday afternoon saying, hey, the glaucoma surgeon said he's going to stop doing iStents after January 1st because he's not going to do them for $34. So it's going to be interesting to see if any of that changes, John.
Yeah, I was glad that Murray brought that up because I was going to chuck that into the chat box. That's a big issue. And I guess there'll be a decision fairly soon on what's going to happen after.
I think Paul got that right. I think,
yeah.
right? He'll be somewhere in the middle.
Yeah.
And clearly, you know, right, most surgeons, no surgeons are Paul saying doing every single procedure. So you do have to make decisions. You know, I think we should focus on the type of glaucoma, you know, and I struggle sort of like with you, John. We've got a lot of very advanced, severe stage patients that are beyond MIGS. And yet I want to make sure that in my impression, that's, you know, the cataract patient with a little bit of glaucoma light are what my students are going to run into. And I'm not trying to teach them every single commercial product out there. That's, you know, that's only good for right now and the next year. And 4 years from now, there's going to be different devices and different products. But, you know, I think something of, you know, Paul's approach, Ike Ahmed's approach of interventional staged approach to glaucoma care and management is what we should be reaffirming with our students, and knowing that there are a number of options of technologies to select from.
If I could dovetail on that, I look from the other perspective. I agree with you. And I think that teaching them how to think and evaluate, because the technology is going to constantly evolve. But if you teach them concepts, you know, uveal scleral flow, teach the concepts and maybe give them the tools to really kind of sniff out what's just hype and what might be real, because it's going to change. So I think your point is an excellent one that you made.
I actually had a little bit of a funny thing a couple of weeks ago in clinic with my 4th years, and I was going through a number of options for our patient, and they were able to name a whole host of MIGS and other procedures, and they couldn't come up with tube shunt options. Now, that's pretty opposite of what we typically do in my clinics and everything, but I was at first annoyed, and then I was like, no, maybe that's where they should focus anyways. Now, I mean, of course, they need to know what a tube shunt is, but I was like, well, maybe I've made some good headway here, and they are able to name all these different MIGS options, but then block out a trabeculectomy and tube shunt options.
I have one more topic, and I think, you know, we had said, I think 5:15 or whatever, so we could end at any time, obviously. I had one more question, and it's about the whole concept of hysteresis and the use of the ocular response analyzer and IOP-CC and so forth. And, you know, what are people doing with that? Are they, first of all, you got to have the device. So without the device, there isn't a lot to say, except that maybe you teach it, even if you don't have the device. And I'll just throw in, you know, at SUNY, some people use it, some people don't. Some people think a lot about hysteresis, some people don't. Anu's shaking his head because he's one of the people who does use the ocular response analyzer. So I was just wondering about that and where people were and what they think we should be teaching regarding that.
We're in the spot where we teach it, don't have it.
Really?
Why'd you say that?
No, I know you guys, you know, you guys have a lot of stuff usually.
Yeah, I mean, I think it's probably, there's value to it. It's easy to sort of dismiss it if you don't have access to it, though.
Yeah, exactly. You know, so if you, well, here's a different question, and you've already kind of answered it. If you don't have the device, how much do you teach about hysteresis and the IOP-CC? So that changes it, but yet do our students need to know about that? Because there seems to be, you know, a lot of opinions about it, you know, even though the literature certainly supports the importance of hysteresis in being predictive for glaucoma development and progression. A lot of evidence. And you may know that David Friedman, and maybe he'll talk about this because I guess he may become one of our speakers at OGS this year. David Friedman wrote a very provocative editorial in the British Journal of Ophthalmology about, it was the end of last year, about replacing Goldman with the IOP-CC measurement on the ORA and making that the reference standard. And, you know, it's interesting. He wrote it with, what's his name, the guy, Gus Grizzard, who is the first author on the light study. So just a 2.5-page read. So if you get a chance to look at it, you know, it's kind of makes you think a little bit.
So we have it and we teach it, and my own personal perspective of not teaching it because, you know, who has it? would be similar to not teaching pachymetry because we don't have a pachymeter. I think if the evidence shows this is substantial, we need to teach it and work on getting it and not teach it because we don't have it. So we taught it before we got it, and now we have it. And I'm the chief of services for the glaucoma clinic, so I require that as part of our protocol, it's done at least once for all of our glaucoma patients. And then, obviously if you need to re-baseline them. We're not using IOPCC because we don't feel we have enough validation of that measure to really implement it as part of our clinical protocol. It's there, we notice it, but we don't really use it. What we use is just the hysteresis, and it seems to have the same impact as pachymetry in terms of how it impacts our clinical care and our decision-making. It has about that same impact. It guides our decision on risks for getting it and progressing. And that's about it so far. We're not really using the other measures that the machine puts out because we need more validation.
Thank you, Bridget.
Drew has a question or a statement.
Yeah, no, actually, Bridget, you kind of answered. I was going to ask, I know how you guys are actually using it in clinic, because, Rich, you and I have gone all around because we did that poster at Academy 4 or 5 years ago, where, given the amount of noise and a limited dynamic range, how much do you actually use it? How much does it actually have impact, right? I think Michael Sullivan and me challenged me in the glaucoma board at one point to come up with something. It was well, yeah, there are some cases where I actually do think it puts me over the top, but it may actually be a fairly limited number of cases, even in concert with pachymetry, as Bridget said. So I'd just be kind of interested to know, how often does it put you actually over the top? I mean, I love having it, but that's another one of these anecdotal, hey, Drew likes having it, but who really gives a crap about what Drew likes? You know what I'm saying? How is that actually actionable? So anyone, and Bridget, I appreciate you starting that convo.
The interesting thing, and we were so excited about getting it. I pushed it. I thought it was going to change everything because I believe the science. And we've had it for 2 years now. It hasn't changed a lot of our decision making, and we look at it to help guide our decision making. It hasn't changed what we would do a lot because you're not going to believe this. We're not finding that many people with low numbers.
Yeah.
We're not. Just anecdotally, what we're seeing doesn't seem to mirror what we've seen in the publications in terms of population studies. We are not seeing, it's not that often that we see people with 8s and 9s that would change our decision making. Most of our people are in the average range. So we didn't get the wow factor we expected because we're not.
Bridget, I think that is a great point. I think they need to scale the values a little bit differently. So you see 10.1 and 9.4 or 9.6, and it's actually that's probably quite a bit. They kind of just got to make it 1,004 and 960 and make the scaling different to get people excited about it, because but if you look at the data and you look at the averages of these, there's a big difference between 9.6 and 10.4. But when you're actually sitting there with a patient, you're looking at the printout, it's is that really such a big deal? So your point's well taken, I think. But certainly the literature supports that there's a lot there.
So Rich, I find exactly what you all are saying, it doesn't change me on a large number of patients, but what I do feel it can be helpful for is identifying the high-risk patients that I might have missed or overlooked a little bit. And, with our patient population, with many of your patient populations, we're trying to identify the high-risk patients and treat them more aggressively. So it's a rare time when it, convinces me to do something that I wouldn't have otherwise done. But when it reaffirms somebody with when I find somebody with low hysteresis, I pay more attention to making sure that we treat them more aggressively and watch them more closely. But I want to bring up one other final question or point, which is a little bit of hesitation of talking and doing it more about it more, is that the follow through on the clinical practice side for most optometrists is so low. So, you know, I don't know where, I'm still struggling with that. They just don't have it in clinical practices in optometry. They're just not buying it. They're not using it. You know, we're a little club of some of us who are doing it. So I'm not saying I'm going to stop teaching it or using it, but how much time for something that they may never run into is an issue. That's, you know, I mean, we could talk, you know, bring in gonioscopy again, but at least they can get a formula lens maybe, but they're not going to get a $17,000 ocular response analyzer.
No, you're absolutely right. And that's obviously not worked well for Reichert.
No.
But I do think that like when someone like Melton and Thomas comes out and says it's like a waste of time, that doesn't help the product or doesn't help us do it. Because I think a lot of people read his stuff. I think.
No comment.
You know, well, I'm just, when you say the general population, I'm just saying a lot of the people respect him and I respect them. And when they come out and say it's, I forget the exact wording, I'm sure you know it, Michael. I think people say, I mean, if we were to talk, let's talk about pachymetry. We all do PACs. In the last 5 years, how many people has it really changed where we put them on a med or not? I mean, yeah, we get it. Yeah, we kind of think about it. But, you know, it's the nerve, the OCT, the fields, whatever. I mean, we could simplify hysteresis to even go to PAC, and yet we all do PACs. But
Well,
Yeah. Go ahead, Drew.
No, I think that's a great point. I guess the thing is that we do these things en masse, and they may not have that much impact in reality to a seasoned clinician's decision-making approach. So what y'all have to decide, obviously from the bench or really from the podium, is how you're teaching the students to incorporate these things. Because you can be very prescriptive, and at least there's a risk calculator off of very good 20 years RCT with ocular hypertension, and you know that may not exist with the hysteresis. So I think that's an awesome point, Maureen, because it's like, you know, how often is it actually putting us over the top? But to Michael's point, is the impact worthwhile on those few number of patients where the impact is worthwhile? I mean, that's really our goal.
No,
So it's
I don't know.
like a number needed to treat thing.
Well, there's no cut and dry. And one thing I do want to mention, I don't know if you guys do this as well, at least what I'm finding is that, you know, the corneal hysteresis value, you know, it can change a little bit. So you have to, I mean, I take it at least 3 to 4 times. You know, it might be a little different in the morning as compared to the evening, just depending on, you know, corneal hydration. You got to look at that wavefront score. So, you know, taking an average of that, I think it's important. The other thing is that, you know, your patients, where the value comes from is essentially your glaucoma suspect patients. Because if you have a patient that is an established glaucoma patient that you're already treating, you usually have pretty good data in terms of progression, both from the field and the OCT, and there's good numbers there for you to judge how well controlled somebody is and what your target pressure should be. So it really just comes down to, here's a patient that's in my chair that's a glaucoma suspect. When am I going to see this patient next? How often should I follow them? How often should I do these fields? And if the hysteresis is low, you might be a little quicker to pull the trigger in terms of starting on medications. But really, that's what it is. And like you said, it's a small percentage of patients. You know, the data that's out there. I mean, you know, luckily when Gus was DeMarias was with us at SUNY, you know, I got to, you know, discuss with him a lot of his work on hysteresis. And there is good data on it. I know Quigley's looking at scleral hysteresis. There's people looking at lamina hysteresis when you start a medication or stop a medication. So, you know, there's definitely data that's on it, and I think it's useful. But I think, to your point, you know, from a practical clinical standpoint, you know, how do we disseminate this to our students? And I think it's very difficult to do so.
Hey, quick selfish question. What are you requiring on Wavefront or on a Wave score or waveform score? Are you
7 and
requiring
above.
6.5? What's
7,
your
yeah,
cut
usually
point?
7.
Okay.
Yeah.
Okay.
Chris Lowe has his hand up.
Yeah, sorry, I was gonna ask if I think Drew had kind of mentioned this just about the risk calculators. How many people, I guess both clinically themselves, but also what they teach their students are utilizing risk calculators for their patients in terms of determining if they're going to treat or not?
Yeah, I think,
We teach the students. I don't think we use it ourselves. And I kind of say like, experienced people kind of have it in their head. And I play a little game with them. We plug in the numbers and let's see who can come the closest. And they get a point. And I usually win. But I think if you have no experience, it's good to know it's out there. I don't think anyone here on this thing uses it in life. Does anyone use it in life? I don't.
I mean, the way that I tend to sort of use it is when I speak to patients about potential risk, and I tell them that this is, these are long-term studies, these are general population studies, and your risk of developing glaucoma in the next 5 years is 20%, so that's 1 in 5. And then, if they want to proceed on medications or not, or we have those discussions.
Oh, that's a good. I don't use it that way. That is a good thought, though. Very good.
I teach my students to use it, but I also think more than teaching them how to use it or is when not to use it, because they'll want to put everybody on it.
Right.
And it is for people who fall into that very specific parameter of the OATS study. And so they'll want to put a pigment dispersion syndrome patient on it, or somebody else. And you're like, no. So, sometimes I'll let the student decide if they want to put the numbers on the calculator and see. And occasionally I'll do it and I might be a little bit surprised, but not very often.
I think it's a nice tool to teach students of the effect of central corneal thickness, for instance. If you just kind of twirl those numbers a little, you can see the risk really jump up. And I think that's a great way to use it.
And also just a bigger picture of how clinical trials can impact our actual legitimate clinical decision-making, instead of just being this thing that's out there in the
Yeah, that's a good
universe.
point.
This has a real specific, this study changed what we did.
To me, one of the biggest things that really changed everything that we did, including buying pachymeters. Michael, I'm sorry, you were going to say something.
Yeah, I was going to say, I do use it a fair amount. And with my students, I tell them, you're never going to have a corneal hysteresis reading to that point in your future, but you have an online risk calculator. And so let's use it on a lot of patients, and let's drill that into you to be familiar with it.
I see Kelly got back on, so I think
We're
our
ready to
time
wrap up.
is done. So now it was great just seeing everybody, quite frankly.
Thank you very much for everything.
And,
putting
yeah,
together.
it was
We
fun.
appreciate it.
So hopefully we'll see everybody at OGS. Michael, you got anything?
Nope. Thank you. Thank you all. Great to be back
I just want to
here,
thank
and,
Kelly. None of this happens without Kelly.
Thank you, Kelly.
Yeah, thanks, Kelly.
Thanks, Kelly. Great job. Thank you.
I can assure you of that.
That's
You're
right.
welcome.
So
My pleasure.
hopefully we'll see everybody in Boston. Kelly, you need anything else from anybody?